We'll move on to the second speaker, who is Dr. Kambis Nail, who's Assistant Professor of Radiology in the Division of Neuroradiology in the Icahn School of Medicine at Mount Sinai, New York. And his work has been widely published in perfusion and brain imaging. His topic today will be reduced contrast dose in stroke and brain tumor MR imaging.
Thank you very much for the introduction. I also like to thank Toshiba Medical Systems for inviting me and giving me the opportunity to share my experience with you tonight. This is my disclosure slide. So the objectives of this presentation is to provide you a brief background of why we need to reduce the contrast dose when we performing DSC perfusion for brain imaging, and I will share with you our initial feasibility study on how to reduce contrast dose, and then I'll discuss the main clinical applications for which I use low-dose DSC perfusion, and I'll share with you some of the clinical cases. So brain DSC perfusion is increasingly used in clinical practice. The two main applications that I personally use DSC perfusion for is for stroke imaging in order to identify penumbra and ischemic tissue, and brain tumor imaging in which we try to characterize tissue and differentiate post-treatment changes from recurrent high-grade glioma. And the current standard dose of gadolinium is about 0.1 millimolar per kilogram of body weight. So why use less gadolinium for DSC? Again, in my practice, the main reason is increased demand for combined multi-enhanced MR applications. Again, for a stroke, I like to do contrast-enhanced MRA and DSC perfusion in the same setting, so I need 2 injections. And for brain tumor, I like to combine DCE, or dynamic contrast-enhanced perfusion, and dynamic susceptibility contrast, or DSC, at the same session, and again I need 2 injections. So the options is to give patients 2 doses of contrast, or to use the same contrast dose, split the dose basically, and perform or accomplish both of these sequences and image acquisitions. Other reasons to use less gadolinium is direct relationship between the risk of NSF and contrast dose. Reduced cost, obviously, would be a good reason to use less gadolinium. And the recent concern, obviously, about the dose-dependent gadolinium administration and the neuronal tissue deposition that we will learn more about probably in the next few years. So what are the challenges in contrast dose reduction? The main challenge is really it relies on our post-processing. So the main way to process DSC perfusion is deconvolution, or a singular value deconvolution. At least it's the most commonly methodology that we use, and that is an ill-posed problem where small changes in your data may dramatically influence the response. And you can imagine, by reducing the contrast dose with resultant lower SNR, this can further accentuate this limitation. I have here an estimation of cerebral perfusion in 2 different SNR setting, a high SNR setting, a low SNR setting. And you can see, if you compare the SVD deconvolution technique with another technique, which is Bayesian, and that's where I'm going to spend most of my time tonight, is in SVD deconvolution technique, basically in low SNR setting, shows higher oscillation and periodically takes negative values when it comes to baseline compared to Bayesian technique. In high SNR setting, they may perform in similar fashion, but in low SNR setting, SVD basically takes higher oscillation and variability compared to Bayesian technique. And the Bayesian probabilistic method is inherently less sensitive. That's based on the published literature to low SNR and has potential for more accurate calculation of cerebral perfusion. So this was really the inspiration behind our pilot study or feasibility study that was published last year in American Journal of Neuroradiology. The purpose was to establish the feasibility of a reduced contrast dose DSC perfusion using Bayesian method and compare the result with the routinely used SVD deconvolution post-processing. So we prospectively included 20 patients. We scanned them at 3T MR scanner. We used 20 coil elements for signal reception. We used a gradient EPI sequence with temporal resolution of approximately 1.5 second. Identical sequence parameters for both half dose and full dose. In every patient, we performed conventional imaging initially, including T1, T2 flare diffusion. And then we did a half-dose contrast DSC perfusion using 0.05 millimole per kilogram gadolinium. We had an 8-minute gap in which we performed our T2 and T1 post-contrast, and then we finished the acquisition by doing a full-dose contrast using 0.1 millimole per kilogram gadolinium. Injection protocol was identical. We used injection rate of 5 cc per second, and we flush each injection with 50 cc of saline. So we use OLEA software to process our images. Both half-dose and full-dose were processed with CSVD and Bayesian technique. And we use co-registered cerebral blood flow, cerebral blood volume, and mean transient time maps from both half-dose and full-dose to perform quantitative analysis. We also looked at noise and SNR distribution. This was these are basically images from a patient who was scanned with half-dose perfusion. I have the noise distribution maps and the SNR. And the same patient scanned with full dose, again, with noise and SNR distribution. You can see that there is, just by looking at it subjectively, you have more noise, kind of expected finding in half-dose group, and the SNR is lower. And then when you do quantitative analysis, we have about 36% lower SNR, or signal-to-noise ratio, in half-dose group, statistically significant, obviously. So this basically another case that was a scan. I have the corresponding flare image here for you, and these are mean transient time, cerebral blood flow, cerebral blood volume, performed with half dose and full dose, all of which processed with CSVD. And you can see that there is some heterogeneity in the mean transient time maps. There is some overestimation of MTT in the left side. And look at the cerebral blood volume. Again, some overestimation of CBV, which you don't see really on full dose group. Again, a homogeneous map on full dose and MTT, but not so much on mean transient time, and effective limitation of low dose contrast. And also this patient has a cortical-based meningioma. Should have a T1 post-contrast image here, but this was, you can clearly see high CBV volume in that lesion, which you barely can see that in high, in low-dose perfusion image. Same patient processed with Bayesian technique, again half dose, full dose, and you can see that the maps are more homogeneous. There's no heterogeneity on MTT maps, and cerebral blood volume, again, you see less of it, but more homogeneous and no significant heterogeneity across the field of imaging. And that cortical-based meningioma, although less conspicuous, but still visible as opposed to CSVD that you couldn't really see that lesion. So let's go to our quantitative analysis. We looked at both gray matter and white matter. We draw our ROI in the central sulcus to evaluate the gray matter perfusion analysis, and these are our results. So looking at gray matter cerebral blood flow, we have significantly less mean difference between full dose and half dose when processed with Bayesian as compared to CSVD, and also much better correlation between full dose and half dose CBF in gray matter compared to CSVD. We looked at cerebral blood volume, again significantly lower mean difference between full dose and half dose compared to CSVD, and better correlation between the two. And when looking at mean transient time, again, less mean difference between the two, and better correlation. And in white matter, as expected, since the perfusion is lower to begin with, these changes were even more dramatic. For white matter analysis, we draw ROI over the centrum semio valley, as you see here. And again, these are our results. So you can see significantly less difference between full dose and half dose CBF in white matter processed with Bayesian compared to CSVD, and significantly better correlation between the two. Again, for CBV, same finding here, better correlation. And for MTT, there was effectively no correlation when the images were processed with the CSVD on half dose. So between half dose and low dose, this is your correlation. And you can see the mean difference between the two was significantly less in Bayesian technique as compared to CSVD. So I'm going to show you some clinical cases. This was a 40-year-old man with multiple sclerosis. He has this expansile lesion, sort of cortical base, and perfusion was requested to evaluate the nature of this lesion. So this patient was scanned with both half dose and full dose group. And again, look at the heterogeneity of map of both MTT and CBV compared to full dose. This is how they should look like, and this is how they look like with half dose perfusion. Let's go to the same acquisition process with Bayesian. Again, you can appreciate more homogeneity across the field of view and similarity between half dose and full dose. Again, same finding on CBV. When you do you can draw ROI over this lesion and look at numbers, and you can see when images were processed with CSVD, we have almost 50% overestimation of mean transient time in half dose category, as opposed to similar, or not similar, but more closer numbers when processed with Bayesian. And again, about 50% underestimation of CBV in half dose category, as opposed to much closer numbers when you look at Bayesian technique. So the clinical applications, as I mentioned briefly at the beginning of the presentation, that I use low-dose DSC perfusion for are stroke imaging or stroke protocol and brain tumor protocol, in which I need to inject I need to have two injections basically to accomplish them. So we have developed this 6-minute MR stroke protocol, and that was published a couple of years ago, in which we accelerate acquisition time to 6 minutes, basically. So we get everything done in about 6 minutes. We perform diffusion imaging. We replace FLAIR with EPI FLAIR to accelerate the acquisition time. We replace GRE with EPI GRE. We replace basically a time of flight MRA of the neck and brain with contrast-enhanced MRA. And we end the study with the DSC perfusion. So again, here you have the option to give 2 doses of contrast or use the standard dose of gadolinium, which is 0.1 millimole per kilogram, dilute that with saline, use half of that solution to accomplish your MRA, and use the other half to accomplish your DSC perfusion. I'm going to show you one clinical case in which I can hopefully highlight the effectiveness of Bayesian to process this type of imaging. This was a 61-year-old woman presented with right-sided weakness and aphasia. She was scanned 90 minutes from the onset of presentation with the NI stroke scale of 17. These are images from our 6-minute stroke protocol. You can see that this patient has left MCA proximal occlusion on MRA, large infarction involving basal ganglia and some of the MCA territory on the left side. There is no flare hyperintensity, indicative of hyperacute nature of this process. There's no hemorrhage on GRE, and there is large perfusion deficit. So again, this perfusion, remember that this is half dose perfusion because we use the other half of contrast for our MRA. So let's process this with CSVD here. So these are CSVD process maps. And these are Bayesian process maps, and I'm going to just focus on 2 slides here, or 2 slices. So these are diffusion, ADC, and TTP, or time to peak maps, and I have a corresponding MTT, cerebral blood flow, and cerebral blood volume maps, and you can see the delineation of hypoperfusion is significantly better on Bayesian technique as opposed to CSVD. The background suppression and the heterogeneity all these regional errors that you see due to low dose contrast is much better suppressed using Bayesian technique. Cerebral blood flow and cerebral blood volume maps are also shown here. You can see very low CBF and CBV. And then if you go one slice lower down, again, large infarction, there's another peripheral kind of like wedge-shaped infarction along the lateral aspect of the temporal lobe. And again, just appreciate the better delineation of hypoperfusion as opposed to CSVD, which is quite difficult to delineate where the perfusion or the hypoperfusion region is. And also look at this infarction, this peripheral infarction, that you can appreciate it on CBF and CBV maps processed with Bayesian. Not so much, I mean, you can see a hint of it, but not as clear as Bayesian processed images. So the second clinical application in which I use DSC perfusion, or the low-dose DSC perfusion for, is brain tumor imaging, as I mentioned earlier. And that's really to differentiate post-treatment changes from recurrent high-grade glioma. I like to use complementary role of DCE in order to evaluate the blood-brain barrier integrity, and also where susceptibility artifact can be problematic, I like to use the DCE to help me to interpret my clinical images. So again, we need 2 injections here, and I use a standard dose of 0.1 millimole per kilogram. I use 40% of that solution to accomplish my DCE, and then the remainder 60% to accomplish my DSC at the end of the examination. So this example highlights the importance of having both DC and DSC, at least in our practice. This was a 54-year-old man with history of high-grade glioma, status post gross solar resection, treated with radiation temozolomide, and he developed this new enhancing lesion at the superior margin of the resection bed. So if you look at your DSC perfusion, and when you superimpose these images, you can see that this lesion is very close to plenum sphenoidale, where there is a lot of air from sphenoid sinus, and therefore when you draw ROI, this basically falls, the majority of this ROI falls on this black hole, and you can really evaluate your DSC perfusion in order to have RCBV analysis. But if you use DCE analysis or perfusion, there is no problem with susceptibility artifact. You can clearly see this lesion that has a very high permeability, a K-trans of 0.28, with this rapid arterial phase that is indicative of recurrent tumor as opposed to post-radiation or post-treatment change. This patient was followed up 3 months later, and you can see that lesion growth quite extensively now. There's significantly more flare hyperintensity. It growth enough away from plenum sphenoidale that now you can appreciate increased RCBV, and also it has increased K-trans with rapid arterial phase. This was pathology-proven recurrent high-grade glioma. So that's why I like to use both DC and DSC, especially in some of these cases that DSC can be limited due to susceptibility artifact. So I'm going to end with 2 clinical examples here showing how, again, Bayesian technique can help me to evaluate my low-dose DSC perfusion. So this was a 59-year-old man with GBM, again, gross solar resection, and treated with radiation and temozolomide. These are follow-up sequential images. There's a small nodular enhancement along the posterior margin of resection bed that has grown on follow-up imaging, and there is more flare hyperintensity. The question was always the clinical dilemma, right? Is it post-treatment changes or recurrent tumor, for which we do our brain tumor imaging, and I have their DSC DSC at the dynamic susceptibility contrast perfusion images here. At the top row are processed with Bayesian, and the bottom row are processed with CSVD. We usually co-register these longitudinal images, and then we draw ROI and to see how the RCBV is changing over time. And I have here for you, when you look at the Bayesian process images, you can see this progressive decline in RCBV values to basically the latest from here is 0.8. That's compared to contralateral white matter. And when you look at the CSVD, you also do see progressive decline, but with higher values. And this is what I teach my fellows, how to interpret these images. If I have RCBV value more than 1.8, we call that a potential recurrence or high-grade glioma. If it's less than 1, radiation necrosis, and if it's between the two, it's indeterminate. That's where we go to K-trans in order to help us tease out more information. And you can see just by using Bayesian, this patient falls within the radiation necrosis category, but with CSVD that would fall in the indeterminate. This was a pathology-proven radiation necrosis. So this majority of this lesion was basically necrotic tissue after surgery. And then this is the last case I have here. Again, a patient with GBM who was treated with radiation, temozolomide. And you can see this progressive decrease in size, maybe not significant, but the lesion is getting smaller. The patient was completely asymptomatic. And again, we do our DSC analysis to further characterize tissue. These are processed with CSVD, and if you look at these co-registered images, you can see that there is initial decrease in RCBV, but then in the follow-up exam, there is increase in RCBV, so that was quite confusing. And then if we look at the same images processed with Bayesian, you can see that there is progressively decrease in RCBV values. There is no increase in later phase, and that really fit the patient's clinical picture in terms of he was completely asymptomatic and the fact that lesion was getting smaller. I don't have surgical pathology for this case. This is like a really fresh case, so we may get surgical pathology or may not. But I really think this if you're performing low dose DSC perfusion in your practice, then Bayesian is probably superior methodology to process your images. If you're doing full dose, it may not make a huge difference, but if you're doing a half dose because of the lower SNR, Bayesian is superior to CSVD post-processing. So in conclusions, reduced contrast dose, meaning 0.05 millimole per kilogram brain DSC perfusion is feasible using Bayesian probabilistic method with comparable quantitative result to 0.1. Bayesian method is less sensitive to low SNR and can result in acceptable quantitative measurements of cerebral perfusion in low SNR environments. Such can be seen with low contrast dose protocols. And described algorithm provides flexibility into your neuro-MR protocols that require multiple injections. So if you're performing stroke imaging with contrast-enhanced MRA and DSC, which requires 2 injections, or brain tumor imaging with DC and DSC, again, requires 2 injections. This provided or described algorithm with using Bayesian technique can help you provide flexibility into your protocols without the need of additional contrast. And with that, I thank you for your attention.